Last year, I sat beside my uncle in a crowded hospital ward. 7 hours, no bed, no specialist. While another family walked in, paid, and saw a doctor in 20 minutes. This is the reality for thousands of B40 Malaysians today. The system that relies on punishes patients for being patient, while prioritizing those who can pay over those whose lives are in the most danger. Every single one of us in this room, or someone we love, will need medical care someday. The current pricing system isn't just a policy debate. It determines whether our elderly parents will wait for hours in a crowded emergency room, while a wealthy patient can pay to legally bypass that wait and see a specialist immediately. I have personally witnessed family members wait for hours in a crowded government hospital ward. Former Health Minister Khairi Jamaluddin agrees that the government is aware that the existing public health financial model is not sustainable and will put additional pressure on federal expenditure. Malaysia must restructure government hospitals based on income levels because the current nearly free system is failing the poor through chronic underfunding, worsening brain drains, and unfair waiting penalties. First, I will explain the 3 major problems facing our public hospitals. Second, I will propose an income-based solution. Third, I will show the benefits this change will bring to every Malaysian. To understand why change is urgently needed, let me first walk you through the 3 problems that make our current system unfair and unsustainable. According to Code Blue report from August 2022, citing former Health Minister Khairi Jamaluddin, patient fees including the RM1 registration charge cover only about 1% of total national health expenditure. Recently, data from Parliament showed that only 10% of houseman positions are filled for January 2026 intake, leaving 4,400 positions vacancies. Every week, 3 to 4 specialists leave public hospitals based on the Malaysian Medical Association. Resignations among contract doctors also increased by more than 1,000 from 2017 to 2022. Public health expert Dr. Zainal noted that wait times have doubled. Patients who used to wait 2 months now wait into 4, and patients who wait to 4 and now wait into 6. To make it worse, the Rakam KKM program legally allows paying patients to skip the queue. Now that I have shown you the severity of these 3 problems, let me turn to the solution that can address all of them fairly. The most effective and fair solution is a third, income-based charging system that asks patients to pay according to their financial ability. Under this system, B40 families would pay the current low rates or receive completely free care for essential treatments, while M40 households would pay a moderate subsidized rate and the T20 patients would pay a higher reasonable fee. Furthermore, this system works because it leverages existing verified income data from programs like eKasih. The government can link financial status to hospital cards. Now, the Minister of Health, Dr. Zulkifli, has defended that Rakam KKM as a necessary tool to generate resources for specialist retention and facility investment, but an income-based model achieves the exact same goals more ethically. Moreover, according to Nick Maharan, this initiative is a proven solution in Germany and Japan. It ensures that higher income groups contribute more to the healthcare fund, which ensure low-income groups are not burdened while creating a sustainable pool of resources. Having outlined what an income-based system would look like, let me now show you the concrete benefits this change will deliver to every Malaysian. Adopting income-based medical charges will produce 3 key benefits that directly solve the problems I have outlined. By implementing a realistic fee for T20 patients, we create an economic future that reduces unnecessary visits. This shift effectively reduced overcrowding and shortens waiting times for B40 families from 6 months back to 2 months. while ensuring a billionaire no longer pays the same RM1 as a single mother. Additional revenue from higher income patients can be reinvested to replace outdated CT scanners and MRI machines, to open weekend clinics for minor cases, and to expand emergency department capacity. With increased revenue from the tier fee system, the government can offer competitive salaries to specialists and improve working conditions for contract doctors, according to Lockman and others. Each doctor costs the nation approximately 1 million to train. Therefore, losing them is both an enormous financial loss and huge reduction in social welfare. In conclusion, after examining the underfunding crisis, the brain drain of our specialists, and the waiting penalty for the poor, one thing is clear. Our current system is failing the poorest Malaysian. Let me now remind you what we have covered. First, chronic underfunding, especially resignations, have doubled wait times for our most vulnerable citizens. Second, we have explored the solution, an income-based tiered system. Third, we have identified the benefits: fairer access, sustainable funding, retention of our medical talents. I ask you to take one critical action today. Sign the national petition calling for income-based medical fees. A single act takes only minutes, but demands a public review of the unfair KKM programs and starts the conversation toward a more equitable Malaysia. Healthcare is a right, not a privilege. Let us build a Malaysia where a mother doesn't have to watch her child waited for 6 months surgery simply because she cannot afford a paying patient scheme. It is time for a system of equal care, not just equal fees, for unequal outcomes. Thank you.